How do you advise patients after preeclampsia or eclampsia after they give birth? What take-home medications or advice will you give them when they should consult back or go back to the emergency room?
If we admit a patient with preeclampsia for, let's say, for control of blood pressure, and then we send them home prior to the delivery, we advise them well on the danger signs that I've mentioned earlier: headache, blurring visions, epigastric pain, right upper quadrant pain, vaginal bleeding, unexplained vaginal bleeding with uterine contractions, etc. Then we tell them to monitor their blood pressure well. Okay, and then to come back if their blood pressure is at least 160 over 100, because that needs an urgent control. When a patient is postpartum already, it's the same, because eclampsia and HELP syndrome, complications of preeclampsia may still happen postpartum. So we tell them to go back if they see those symptoms, and then if their blood pressure is at least 160 over 100.
Follow-up question to that is, do you give methyl dopa as a take-home medication?
Yung methyl dopa, like any other antihypertensive medication, we give it for treatment. We do not give it for prophylaxis. So we do not give antihypertensive medications if the patient has normal blood pressure. Some of the patients with gestational hypertension, after they deliver, their blood pressure goes back to normal right away. So in those cases, we do not need to give them antihypertensive medications anymore. We give methyl dopa if we need to control the blood pressure. Now, postpartum, we still prefer giving methyl dopa, but careful in patients who are prone to depression, like postpartum depression, for example, because it may worsen when you give methyl dopa. That's why in some patients, we give calcium channel blockers such as nifedipine or amlodipine.
There's quite a few questions about tranexamic acid or TXA. About TXA or tranexamic acid, they're asking if you can give it preemptively, like prior to cesarean or prior to delivery, give the tranexamic acid as a prophylaxis against postpartum hemorrhage.
There's this large trial, the woman trial, no? So they found that tranexamic acid is very good in preventing postpartum hemorrhage. So you can give it just before, no? You can give 1 gram. But for most of us, we give it before. We could just give it once it start, because you can, it stays naman for 7 to 8 hours in the plasma. So you can give it to prevent postpartum hemorrhage. No, it's true. No? As I mentioned that earlier, just didn't give the dose, so you can give 1 gram. So it's and it's been proven safe in that large trial. In fact, it doesn't even appear in the breast milk, so you can give it safely. Yeah.
Yes, it's actually what, just to add to Dr. Hermar, most anesthesiologists will already give 1 gram
Yes.
tranexamic
Parang,
prior to
yan ang best
starting.
friend
Yes.
ng
It's
OB.
like a vitamin. And ng
Yes,
anes.
yes,
Obstetric.
kulit na kulit ng
Yes.
anas sa amin, di ba? For even
Yes,
just,
yes.
even not only for obstetric hemorrhage, also for gynecologic surgeries, di ba?
Yes, yes. We already give it.
Walang katapusang pakibigay ng Xanax.
Vitamins na siya. I mean, joke.
Yes, yes.
We call it like vitamins. Yes, doctor.
The world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share. Every second counts. Live integrated tele-ultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated tele-ultrasound collaborative platform. Philips Lumify. Integrated tele-ultrasound powered by React's collaborative platform. Innovation and you. Philips.
Another question is regarding balloon tamponade. Is there a special device like a pre-made and type of catheter, or is this like a makeshift balloon tamponade? And how many ml of saline do you
So
put
the
in?
one that should be useful is yung the Bakri catheter, the one I showed earlier.
Yes.
But most catheters that are used for this purpose, for postpartum hemorrhage, single balloon catheters, would usually need, I saw a question earlier, hindi ko lang nasagot daya ni Lear kasi Lear had time to answer. But 500 ml, usually 500 ml, yung the one that the manufacturers would suggest, or the suggested amount, maximum amount, no? But some siguro dahil sa mga very anxious obstetricians, it can even hold us up to 2 liters nga eh. But yung manufacturer required or recommended maximum amount is 500 ml that you infuse into the catheter. Of course, in PGH, we've tried everything no, to create tamponade. Pero kasi yung mga balloon catheters na we use for the bladder, di ba? It cannot hold as much as 500 ml. So the most that you can do ng tamponade na yun, I don't think baka siguro up to 100 or baka pumutok lang din eh. So what we've used before would be the gauze. Pero if you have it in your centers, it's better to get the one that's commercially available. The Bakri, there's also the Utah Medical, and there's another one, the EBB Complete Tamponade System. Pero the one that we've used is the Bakri.
This is also, I think, related to hemorrhage, postpartum hemorrhage. What is the hemoglobin level threshold for transfusion?
Dr. Sherry can answer that. But but the postpartum, well, kung halimbawa it's right after delivery, so you look at your blood loss, you look at your parameters, no? So if your blood loss is more than the allowable blood loss based on your pre-op hemoglobin or baseline hemoglobin, so at least a 10 to 15% decrease in your hematocrit is already considered hemorrhage. So you can also already think of transfusing. And the table I showed you earlier, so of course when your patient, so aside from quantifying the blood loss, which the anesthesiologist would always remind us to do, or they do it na, di ba? Kasi they will already say, Doktora, magto-transfuse na tayo kasi medyo tayo we're so focused on, lalo na pag vaginal delivery, we underestimate the blood loss eh. Pagtingin mo sa tawag namin ni Lair, yung balde sa ilalim, sobrang dami ng blood. So another thing that's more important than the hemoglobin level, even before, kasi pag nagkuha ka ng hemoglobin, that's a bit, it takes time. It's more the, like if the patient is tachycardic, tachypneic, the systolic blood pressure goes down, or worse, if she's already hypotensive, then of course you should already consider transfusing blood, no? And then yun na nga, quantify your blood loss and correlate it with your vital signs and your clinical parameters. Yeah.